up to 30 out of 100 women who undergo a major permanent surgery to reconstruct their pelvic floor will eventually have that surgery fail, or, they'll need it redone completely in the future.
Yeah, which is just a staggering statistic.
Right. I mean, that is straight from the Royal College of Obstetricians and Gynecologists, 30%.
Massive. And it immediately forces you to ask, what exactly is failing inside the body?
Exactly.
And why are so many women undergoing these really intense anatomical reconstructive procedures in the first place, especially when a lot of times they've already tried these heavily marketed non-surgical alternatives?
Right. So today, we're shining a massive spotlight on a topic that is widely experienced by so many of you listening, but honestly, it's rarely discussed with actual mechanical clarity. We're talking about the physical changes to the pelvic floor.
Yeah, it's so misunderstood.
It really is. So we are looking at a huge stack of medical guidelines today to figure this out. We're pulling from the National Institute for Health and Care Excellence, or NICE, as it's called.
The big one.
Yep. Also, the Royal College of Obstetricians and Gynecologists, Stat Pearls, the Cleveland Clinic, the American Society of Plastic Surgeons, and several dedicated women's health clinics.
It's a lot of material.
It is a lot. But our mission for this deep dive is to demystify one crucial, highly misunderstood question for you. What is the actual difference between vaginal laxity and pelvic organ prolapse?
Yeah.
And importantly, exactly when is prolapse surgery strictly more appropriate than, just a tightening procedure?
Right, because navigating these options requires us to completely strip away the cosmetic marketing, the stuff that just floods our social media feeds.
Oh, the ads are everywhere?
Everywhere, and we need to look objectively at the anatomy instead. It really comes down to understanding the fundamental difference between a sensation, which is laxity, and a structural shift, which is a prolapse.
Okay, let's unpack this.
Yeah, the goal today is to empower you to understand the real science behind these advertised treatments so you can actually make sense of what is happening mechanically in the pelvis.
So we have to define the two distinct conditions at play here because, well, clinics and advertisements jumble them together constantly.
They do. They use the terms interchangeably, which is so confusing.
Totally. First, we have vaginal laxity. According to the sources, this is primarily a feeling of looseness.
Right. It's a sensation.
Yeah. It usually stems from a loss of collagen and elastin in the vaginal tissues.
Yeah.
We see this happen a lot after childbirth, or honestly, just from the general aging process.
Or dropping estrogen levels during menopause.
Exactly. Estrogen is critical for keeping that tissue plump and elastic. But then, on a completely different mechanical level, you have pelvic organ prolapse, or POP.
Yeah, and this is where the distinction is vital. While laxity is about the quality of that surface tissue, prolapse is a profound failure of the deep support structures holding everything up.
The actual mechanics.
Exactly. The pelvic floor muscles, the connective tissue, which is called fascia, and the ligaments actually weaken or tear. Yeah. And when that happens, your pelvic organs, like the bladder, the uterus, or the rectum, physically drop down into or even protrude entirely outside of the vaginal canal.
I always try to visualize the pelvic floor like a hammock.
I love that analogy.
Right. So if you think about laxity, it's like the actual fabric of the hammock is just getting stretched out over time. It's lost its bounce, it's lost its elasticity.
Yeah, exactly. And following that same logic, prolapse is what happens when the heavy wooden posts holding that hammock up to the trees start to rot and collapse.
Oh, wow. Okay.
Right. The fabric of the hammock could be in perfect condition, but because the posts are giving way, the entire structure drops. And whatever is sitting inside of it, so your pelvic organ starts to physically fall out.
It makes complete sense why distinguishing between the fabric and the posts matters so much clinically.
It changes everything about the treatment.
Right. The Cleveland Clinic points out that while the sensation of laxity can sometimes be an early warning sign of a prolapse, they are emphatically not the same thing.
Not at all. Prolapse creates a physical, visible bulge. It creates this really intense pelvic pressure.
Doctors actually classify prolapse based on exactly which organ is falling, right?
They do. So if the bladder is bulging into the front wall of the vagina, that's an anterior prolapse or a cystocele.
Okay, systole.
Yeah. If the rectum is pushing into the back wall, it's a posterior prolapse or a rectocele. And if the uterus itself is dropping straight down the middle, that's an apical prolapse.
Laxity, conversely, does not present with a visible bulge of organs.
Right.
It primarily impacts sensation, sexual satisfaction, and body image.
Yeah.
The organs are still exactly where they're supposed to be, but the interface just feels different to the patient.
Exactly. And Because laxity is all about that stretched out fabric of the hammock, both the medical and the aesthetic industries have engineered, a million ways to try and rejuvenate that exact tissue.
Oh, it's a massive multi-million-dollar trend. These Titan procedures.
Oh, yeah.
We are talking about heat, lasers, scalpels. Let's look at the non-surgical ones first. You have these energy-based devices.
Right, the lasers and the radio frequency.
Yeah, they use radio frequency. You'll see brand names like Thermava or VVev, and CO2 lasers, like the new V laser. And honestly, the mechanism they use is wild.
It sounds like sci-fi.
It really does.
Hmm.
They literally heat the vaginal tissue to about 40 to 45 degrees Celsius to create intentional micro-injuries.
Yeah, it's a process of controlled trauma.
Wait, if lasers and radio frequency are just boosting collagen in the upper layers of tissue, isn't that just treating the symptoms instead of fixing the root cause?
Well, what's fascinating here is that, yes, it is just treating the surface. When the heat penetrates the mucosal layers of the vaginal wall, the body's immune system registers it as an injury.
Okay.
And this triggers a natural healing cascade. Fibroblast cells rush to the site to repair the thermal damage by producing fresh, new collagen and elastin fibers.
So you're basically tricking the body into rejuvenating its own tissue.
Exactly. This improves the overall firmness of the vaginal wall. It helps significantly with vaginal dryness by increasing local blood flow, and it can even alleviate very mild stress urinary incontinence.
Which is when you leak just a little bit when you cough or sneeze, right?
Right, exactly.
But, I'm reading the claims on these laser clinic websites, and frankly, I'm pretty skeptical about how they are marketed.
Oh, you should be.
If a patient's actual pelvic floor muscles are failing and dropping, are these devices just burning the surface tissue and totally ignoring the structural muscles that are actually causing the problem?
The Cleveland Clinic addresses that exact concern, actually. They confirm that these non-surgical energy-based treatments do absolutely nothing to tighten the underlying pelvic floor muscles or ligaments.
Nothing at all.
Nothing. They are exclusively treating the surface tissue quality, not the deep muscular support.
Right.
And because the body's collagen naturally degrades over time, the results are strictly temporary. Most clinics require patients to come back for retreatments every 6 to 12 months just to maintain that superficial collagen boost.
Wow, so you're just on this endless cycle of laser treatments.
Exactly.
But even when we look at the surgical option for laxity, which is vaginoplasty, it has serious limitations too.
It really does.
A plastic surgeon or a gynecologist physically cuts away excess mucosal tissue from the vaginal lining and sutures the superficial muscles closer together to narrow the canal.
Right.
But looking at the biomechanics, it's really only closing the gap where the vaginal muscles have stretched apart at the opening. It is not reconstructing that deep pelvic suspension system that holds the bladder or uterus in place.
Exactly. A vaginoplasty will give the patient a tighter canal, which effectively addresses the primary complaint of laxity and loss of sensation. But if there is a true structural descent of organs, narrowing the opening of the vagina does not stop the organs from pressing downward. Gravity is still pulling on those weakened internal ligaments.
So if the tissue is literally tearing and the organs are dropping past the vaginal opening, a laser or a cosmetic tightening just isn't going to save you.
No, gravity has won at that point.
Right, gravity is one. This is where the medical guidelines completely shift away from aesthetics and move into major structural reconstruction. If a patient has a physical bulge from a drooping bladder, trying to laser the vaginal wall to create collagen is going to do nothing.
It is functionally useless for resolving the anatomical drop. When organs descend, we are looking at a profound mechanical failure of the pelvic fascia and the uterosacral ligaments holding those organs up against intra-abdominal pressure.
That intra-abdominal pressure is no joke.
It's constant. So, to determine the severity of this, urogynecologists use a highly specific, standardized measurement system.
Yeah, our stat pearl source goes deep into the biomechanics of this. They use the pelvic organ prolapse quantification system, or POPQ.
Yes, the POPQ.
It sounds incredibly clinical, and reading through how it's actually performed, you realize how invasive and honestly vulnerable this measurement process is for the patient sitting in the exam room.
Oh, absolutely. But the POPQ is the international gold standard because it removes the guesswork. It is a precise grid system.
How does it actually work?
Well, the doctor measures the descent of the pelvic organs in centimeters using the patient's hymen as a fixed 0 point.
Okay, so the hymen is 0.
Right. Anything above the hymen inside the body is a negative number, and anything protruding past the hymen outside the body is a positive number.
Wow. Okay.
Yeah, they are looking for the leading edge of the prolapse. If that leading edge is dropping right down to the hymen or protruding centimeters past it, the patient is diagnosed with a stage 2, stage 3, or stage 4 prolapse.
Going back to our analogy, if a patient is stage 3 and their bladder is literally descending past the vaginal opening, using a radiofrequency wand on that tissue is like trying to fix a collapsing suspension rudge by pouring a fresh layer of asphalt on the road.
That is a perfect way to put it.
Right. The road might look smooth on top, but the steel cables holding the bridge up are still snapping.
Exactly. When the POPQ scores map out a true structural collapse, and the patient is experiencing the associated physical symptoms like a heavy dragging sensation, chronic pelvic pressure.
Or having to physically press their fingers against their vaginal wall just to have a bowel movement.
Yes, exactly. When that is happening, the clinical approach changes entirely. Aesthetic tightening is completely off the table. We move into the heavy-hitting reconstructive surgeries designed to rebuild the internal architecture.
Here's where it gets really interesting, because the surgical arsenal laid out by the British Society of Urogynecology and the RCOG is intense.
It is major surgery.
This is a massive shift from a quick 30-minute laser session at a med spa to, like, major reconstructive surgery in an operating room. Let's look at the actual biomechanics of these procedures. First, we have colportophy.
Right, the traditional repair.
Yeah, it's the repair of the anterior or posterior vaginal walls. The surgeon literally makes an incision, pushes the bulging bladder or bowel back into its proper anatomical position, and then tightly stitches the patient's weakened native fascia together to hold it there.
And when the top of the vagina or the uterus itself is dropping, surgeons use suspension procedures.
Okay, like what?
Sacrocolpopexy is a major one. This involves using a piece of synthetic mesh to physically suspend the top of the vagina to the sacrum, which is the bone at the base of the spine.
Okay.
So the mesh acts as a permanent artificial bridge, replacing the broken uterosacral ligaments and fighting against the downward pressure of the abdomen.
The history of that synthetic mesh is heavily featured in these guidelines, and it's highly controversial, isn't it?
Oh, incredibly controversial.
Yeah, I read that it was originally used for abdominal hernias and seemed like a miracle material for pelvic floor repair. But the pelvic floor isn't a static wall, right? It's a dynamic, moving hammock.
Yes. If we connect this to the bigger picture, because of that constant movement, the rigid synthetic mesh sometimes eroded directly through the soft vaginal tissues.
Oh my gosh, that sounds horrific.
It caused severe chronic pain, painful intercourse, recurrent infections. The complications were so profound for a subset of women that the use of transvaginal mesh is now heavily regulated globally.
Right.
Today, procedures like sacrocolpopexy are usually done abdominally to minimize that vaginal erosion risk. And they require extensive shared decision-making between the patient and the surgeon about the long-term risks.
Well, for patients who want to avoid mesh entirely, there is sacrospinous fixation.
Yes.
The surgeon stitches the top of the vagina directly to a very strong, thick ligament deep in the pelvis, relying entirely on heavy, permanent sutures instead of a mesh bridge.
Right, which avoids the mesh complications.
Exactly. But looking through the RCRJ data, there is another procedure called colpoclysis, and the mechanics of this one are just fascinating.
Colpoclysis is a highly effective, albeit very permanent, option. It involves partially or completely denuding the vaginal lining and sewing the anterior and posterior walls of the vagina shut.
Wait, they literally close the canal.
They do. It essentially obliterates the vaginal space entirely, creating a solid wall of tissue so that no organs can physically prolapse down through it.
I mean, that is just, wow. That is a permanent solution.
It is. It is generally offered to older women or those in poor medical health who cannot tolerate a lengthy, complex reconstructive surgery, and crucially, who are absolutely certain they no longer desire penetrative vaginal sex.
Right, of course.
Because the surgeon doesn't have to navigate deep into the pelvis to reconstruct ligaments, it has an incredibly high success rate, a much shorter time under anesthesia, and significantly lower surgical risks.
It is a vital option for patients whose primary goal is just symptom relief and daily physical comfort without the massive toll of a deep reconstruction.
Exactly.
But looking at the broader picture of all these prolapse surgeries, the NICE guidelines and the patient decision aids are really blunt. This is major surgery.
Oh, absolutely.
It carries the standard risks of infection, bleeding, blood clots, and a very slow return to normal daily activities.
And that brings us back to the statistic we opened with. The reality is that approximately 25 to 30 out of 100 women who have reconstructive surgery for prolapse will develop another prolapse in the future.
It's just wild to think about.
A 30% recurrence rate really highlights a fundamental truth about pelvic biomechanics, which is that surgery is not an invincible cure.
I was trying to understand why it fails so often. It really comes down to that intra-abdominal pressure.
Yes, completely.
Like if a patient has a sacral popexy, but they go back to heavy lifting at work, or they experience chronic coughing from asthma, or they struggle with severe chronic constipation, they're putting immense downward force on those repairs every single day.
Every day. The downward pressure of bearing down or lifting heavy objects can eventually snap the sutures, stretch the native tissue again, or cause a new prolapse to occur in a different compartment of the vagina that wasn't surgically reinforced.
All right.
Like if you fix the front wall, the back wall might give out a few years later.
So synthesizing all of this for you, the listener, who might be staring at a brochure from a laser clinic or sitting with a referral to a urogynecologist, what does this all mean for you, and how do you navigate this decision?
Well, the clinical divide becomes very clear when you look at what is actually failing in your anatomy. If your primary concerns are a loss of physical sensation during intimacy, a feeling of looseness, vaginal dryness, or very mild stress urinary incontinence.
And a clinical exam confirms your organs are still supported in their proper place.
Exactly. Then the tightening route is entirely appropriate. Non-surgical energy devices or surgical vaginoplasty directly target those specific quality of life and surface tissue issues.
But, and this is the core answer to our mission today, prolapse surgery is strictly more appropriate and medically necessary when there is a physical anatomical descent of your pelvic organs.
Yes.
If you have a bulge, you can feel chronic pelvic pressure, or you have to physically assist your body to have a bowel movement, a collagen-boosting laser or a superficial tightening is not going to help you. Gravity's pulling your organs down, and you need reconstructive surgery to restore the mechanical support of your pelvis.
But it is also crucial to explore the middle ground before ever reaching for a scalpel or scheduling a laser appointment.
Oh, absolutely.
The medical guidelines strongly prioritize conservative management first. Pelvic floor muscle training, specifically cable exercises, directed by a specialized pelvic floor physiotherapist, can significantly improve the symptoms of mild to moderate prolapse.
Just by bulking up those muscles.
Right, bulking up the muscles that act as the foundation for the ligaments.
And we absolutely have to talk about pessaries. The success rates on these are incredible.
Pessaries are fantastic. They are medical devices, usually made of medical-grade silicone, that are inserted directly into the vagina to manually prop up the dropping organs.
They come in various shapes too, right?
Yeah, they do. Like a ring pessary that sits behind the pubic bone, or a Gellhorn pessary that uses a slight suction effect to stay in place.
That is so clever.
They physically hold the structural drop at bay. They are incredibly effective biomechanical tools. Up to 77% of women who opt for a pessary are still successfully using it a year later to manage their symptoms.
77%.
Yeah, allowing them to avoid surgery entirely, even with advanced stages of prolapse.
It's all about matching the tool to the reality of the anatomy. You don't lay asphalt over a snapping suspension bridge, and you don't need to rebuild the wooden posts if the hammock fabric just needs a little mending.
Beautifully said.
Thank you for joining us on this deep dive into the mechanics of the pelvic floor. It is a landscape filled with whispered conversations and confusing marketing, but we hope this provided a clear shortcut to being deeply well-informed about what is actually happening in the body.
Which leaves us with a final thought to ponder. Given that aesthetic tightening procedures are known to be temporary, and that up to 30% of these major permanent reconstructive prolapse surgeries eventually fail or require revision, are we perhaps expecting too much permanent anatomical perfection from our bodies?
Oh, wow. That reframes the entire conversation.
I think so. Instead of viewing the pelvic floor as a static, rigid structure that must be permanently fixed the moment it changes, perhaps we should view pelvic health as a lifelong, evolving management process.
Like it's a journey.
Exactly. One that adapts as we age, using different tools like physiotherapy in our 30s, perhaps a pessary in our 50s, or surgical intervention only when functionally necessary, rather than constantly chasing a permanent reset to the body we had before childbirth or menopause.